morning, everyone, and welcome to UCT online ENT platform. I'm Dr. Agata Bizos. I'm one of the ENT registrars of the Department of ENT, and I will be presenting this morning my research presentation, which I was fortunate enough to present over the weekend at the South African Pediatric Association conference. I would like to just acknowledge my supervisor, Professor Shazia Peer, as well as the other authors involved with the study, including Dr. Dennis Katundu. These are my disclosures. Now we'll just start off with a clinical picture of a child presenting and with the typical features of one can appreciate on flexible laryngoscopy of laryngomalacia. So laryngomalacia is the commonest cause of stridor in infants and presents shortly after birth with a variable severity. The noisy breathing is created by an atypical anatomy of the supraglottis, the area above the vocal cords, and management or treatment is usually conservative. These are the typical features of laryngomalacia, the hallmark features that one can appreciate on flexible laryngoscopy, which include an omega-shaped epiglottis, short aryepiglottic folds, as well as bulky scissoring of the aryetinoids. And these children usually present with stridor. Their stridor is usually inspiratory, but can be variable, and it worsens when feeding or excited. The intensity and frequency of their stridor does not, however, imply the severity of the laryngomalacia itself. And these children go on to have complications such as feeding issues with associated failure to thrive. They have an associated diagnosis of laryngopharyngeal reflux, gastroesophageal reflux disease, and they can suffer from sleep apnea. And so is surgery needed for this disease? So laryngomalacia is a very prevalent condition, but over 80% of children don't require any intervention. And the remaining 20% of these children that do need medical therapy to assist with feeding and upper airway symptoms, only of these 20%, 10% of this group will require surgical intervention to manage their symptoms. If their symptoms are very severe and multifactorial, and we would opt to do a tracheostomy for these children. However, if moderate to severe, then a supraglottoplasty can be done to improve the laryngeal inlet. And, so knowing which children need more than medical management is key to best practice. And which children should, in fact, be referred to ENT specialists is of utmost importance. So what are the factors influencing the need for surgical intervention? For example, supraglottoplasty, surgery, or tracheostomy is one of the questions we were asking in our study. And so surgical decision-making is crucial in providing minimally invasive surgery to symptomatic and affected individuals. The indications for surgical intervention usually include failure to thrive, a worsening persistent stridor, which is biphasic and present at baseline, and children who have no change in symptoms after 2 weeks of commencing anti-reflux treatment. In cases of severe upper airway obstruction, a tracheostomy may be the first and best option to bypass the laryngeal inlet. So this was a retrospective study of all children who underwent supraglottoplasty for laryngomalacia by a single airway surgeon in South Africa over the past 6 years, from 2017 to 2022, at 2 different hospitals. And these were our methods and materials. It was a chart review of the clinical presentation, demographics, medical therapy, surgical notes, perioperative and postoperative reviews, and the time period range as stated before. The objectives of the study included determining the clinical factors in symptomatic children with laryngomalacia that underwent intervention, their surgical outcomes, and also to identify those who initially required a tracheostomy and whether those children who had a tracheostomy thereafter required a supraglottoplasty to decannulate them. So if you can have a look at this before and after picture on the right of supraglottoplasty surgery, one can really appreciate how amazing the results really can be in opening up and uncurling the laryngeal inlet to allow these children to breathe better and improve. And again, these images just do justice for what the surgery actually does in opening the laryngeal inlet and allowing these children to be less symptomatic and go on to thrive. The first step and the most common step in most of the children done by cold steel within our institutions involved right and left aryepiglottic fold trim. And for most of our cases, this was the only step required to improve the laryngeal inlet to aid these children in being less symptomatic. With regards to our results, there were 42 patients included in the study. 95% of these patients underwent supraglottoplasty surgery. 85% of them received exclusive supraglottoplasty. 5% of children required a tracheostomy post-supraglottoplasty, and only one patient required revision supraglottoplasty surgery. With regards to our tracheostomy results, 8 out of 42, 19% of children underwent a tracheostomy. Initially, 6 children of the cohort or patients needed tracheostomy primarily due to their severe laryngomalacia, and 4 out of 6 patients later received supraglottoplasty for decannulation support. And so there are only 2 children left with a tracheostomy for their severe symptoms of laryngomalacia. With regards to our clinical outcomes, there was a 91% resolution in stridor, a 94% improvement in weight gain, as well as subjective improvement in child's well-being from the parent, and only 2 out of 34 children, which is roughly about 6%, had no change post-supraglottoplasty surgery. And these are the children who should have had a tracheostomy rather than a supraglottoplasty for their corrective surgery. This is just a weight progression across time post-surgery. One can appreciate how the weight gain slowly did progress and increase for most of the patients post-operatively. As stated before, 94% of patients had an increase in weight gain post-operatively. And so in terms of tracheostomy, in select cases, a tracheostomy is still indicated, and supraglottoplasty cannot bypass a tracheostomy where it is due. Of our cohort, the children requiring tracheostomy were those with severe multifactorial upper airway obstruction and the complications or sequelae thereof, which included severe failure to thrive, poor feeding with non-resolving upper airway obstruction, and chronic respiratory failure. In terms of our perioperative complications, there were no perioperative complications observed in patients who underwent surgical correction. The modal time to feed orally was 1 day, so they had 1 day of nasogastric tube feeds and thereafter went on to have oral feeds. And the modal duration of ICU stay was 1 day. However, as one can see on the bar graph on the right, there were some children admitted in ICU for one child for up to 20 days, and this was due to factors other than their supraglottoplasty surgery. So in conclusion, for most cases of laryngomalacia, we can effectively manage these children with conservative approaches. However, in specific instances involving failure to thrive, worsening persistent stridor, and an inadequate response to anti-reflux treatment, consultation with an ENT surgeon becomes imperative, and this step allows for consideration of corrective surgical interventions, such as supraglottoplasty. So the take-home message is that we recommend early referral to a pediatric otolaryngologist for all refractory cases with symptomatic upper airway obstruction and feeding issues. This also allows for the confirmation of the diagnosis of laryngomalacia, or other children who present with symptomatic laryngomalacia that are refractory to medical treatment. Other comorbidities or pathology of the larynx can be excluded, and surgically and clinically indicated children, the surgical procedures that we can offer can dramatically enhance feeding, quality of life, and especially facilitate improved breathing and airway control. And these are my references. Thank you.
Thank you. That's a really excellent presentation. Yeah.
Just take any questions to the floor.
Maybe I can ask, I mean, the patients that had supraglottoplasty that had tracheostomies from before, how long in general did it sort of take before they considered decannulation in relation to their supraglottoplasty wounds? Like, so if they had the intervention for supraglottoplasty, when did we start considering whether or not they were decannulatable? Did we wait like 3 months or 9 months or what?
No, a few years. A few years.
Okay, so even if they had, you would wait a while.
Still wait for them to outgrow their laryngomalacia, but if it still was persistent, then put up to 3 to 4 years. Decanulated.
Have you made any the sick version of the Red Cross? Some of these are yours, yeah. Can you just in terms of indications of the approach that I think this refers 2 slides or so more, but just in terms of indications,
Do you know which
it might be a bit ambiguous when you say the patients that haven't responded to PPI. Usually those are the patients with moderate to severe disease only, because you wouldn't consider it in a child who's otherwise gaining weight with failure to thrive.
No, so
soft stride, or
yeah, so
probably just still observe them regardless of their responders at PPI. And the feeding, the work with the speech therapy, you know, kind of the
not necessarily. It didn't really.
But has that been proven in the literature to be beneficial? You know, are you supposed to position the child upright so that?
Yes, well, speech. So these children were children who didn't respond to any of the conservative measures, including speech, but not all of them were necessarily referred to speech therapy for those measures.
And linked to what Louisa asked, how many kids were decannulated? You had a tracheostomy prior or post?
So I've got that data here. So 8 children in total required a tracheostomy for isolated severe laryngomalacia. And 6 out of those 8 children would require a tracheostomy primarily. So 2 of those children actually still required a tracheostomy post-supraglottoplasty. So those were essentially failed supraglottoplasty patients. And then out of those 6 patients, 4 out of the 6 are currently decannulated. So I think that's about 66%. The other 2 are still have had recent surgery.
And then did any of the patients that, all the patients in your cohort, did they only require epiglottic fold release? Or did there any of them require any additional intervention over and above that?
The majority of them required epiglottic fold release.
Yeah.
That's the first step.
Yes.
There was one child who required revision, epiglottic fold release, and then had a bit of debulking of the areatinoids. But what's described in the literature as a epiglottic fixes, is not documented as informed.
So if a parent brings you a child who's got stridor but not requiring surgery, how long will you tell the parent it will take for it to be resolved?
So
with the management.
Without surgical management. So usually these children do resolve, so up to the age of, so laryngomalacia typically resolves what's described in the literature at the age of up to 2 years. So if it's persistent beyond the age of 2 years, or if the symptoms are so severe that they're really struggling with failure to thrive and severe failure to thrive, difficulty breathing, and features of upper airway obstruction, one will opt to do the surgery before that. However, conservative management can be applied for up to 2 years for these children.
3 years, okay. I was just thinking whether you manage children who come from far away differently. I presume that if you've got a child who's who you could observe in the city, if they do get an upper respiratory tract infection, I'm wondering whether they would decompensate immediately. So I'm just asking whether one would be more ready to do almost a prophylactic procedure. I don't know, I'm just putting it to you.
Yeah. So I didn't actually look at the distance or demographics of these patients, but one would imagine that because the surgery does have good results and children are severely symptomatic, then you could opt to do the surgery prophylactic or preemptively to.
Yes, I'm bringing it to you to know what Charlotte thinks about that, because what's that feel?
Yeah, I mean, I think it does depend on, and they're tricky. I don't have a right answer to that, but I know when I was thinking that was always an issue because patients, it's like, even if you're in that drainage area, transport's unreliable, and then there's like a 3-hour drive. If you're living in the opposite, the other end of it, contrary to that one time, anyway, it's far.
But
there was, it's, but it's close, sort of on the border of, it's quite far.
Yeah.
So, it's like a 5-hour drive
Yes.
to the hospital,
Yes.
and it's not like
It might be worthwhile just asking Charlotte about that, whether you would manage slightly differently or not.
And then just the last comment, Aggie, in your study, that it just goes to show we've had really good results with cold steel. And maybe for other people listening, we don't use laser at our institution for this. And we've had some really horrific results when laser has been attempted in other institutions that have subsequently been referred to us. So I don't know if Prof. Pierce on the call, but I think your study just goes to show you can have a good result with cold steel, and you don't need to attempt laser. And actually, you've seen a few cases that have had really horrible results after having laser done specifically.
There's a lot of research out there which actually already shows that cold steel is the preferred method for the supraglottis, and that this is an effective, safe, minimally invasive procedure for the larynx.
is it the laser? Is it the amount of thermal management?
My understanding is that it's twofold. Maybe Adam knows better than that, but it's the thermal injury, and then it's also if you're doing too much.
Yeah.
So it's the
But I wonder if you
excessive
put the laser you're doing
debulking
too much,
and
if you
debulking your retinoids and you're incising pericarditis before so you have quite significant scarring. And all those kids.
I think laser, I think a bit with need to have tension in the tissues. With the moment you lasering issues just floppy. Just cause lots of and so I think it's really a matter of the need hands.
Yeah.
I remember having a presentation at the American Academy on photo surgery, and most people use cold steel, but the person also referred to the colleague in South America who does all the laser from fantastic results. So I think it's a matter of probably these hands exist, and but laser can put a lot of power.
Yeah.
But can be great. Some people use often they don't use it. Yeah.
I mean, I think if you're working at a place like Red Cross and airway is your thing, you're going to be doing lots of airways. But if I were working, say, in wherever, you know, in the middle of nowhere, I'm going to do the occasional case. I'm not going to be doing this every week. So my results are probably not going to be as great as someone who's, you know, doing this every single week and do this at a policy.
At least at our institution, we use a bit of a mix. I think it depends on the goals of your surgery. For the area robotic folds, we typically do cold steel, which I think just lines really nicely to what you're trying to do. We do quite a bit of laser for roboticexy. It's actually quite nice if you get it right in kind of that right within the molecular, right within the blasto ligament. It's really nice. You can see with almost with each pulse of laser, the epiglottis kind of just crimps up. Yeah. So I think just being conservative with the laser is probably the most important thing. I've never seen us use laser on the 80 folds or the auriculates. Occasionally we will debulk the auriculates with the ablator, but we usually reserve the laser for that. And then there's occasionally, I mean, we have a difference in our attendings. Some will throw a stitch for the epiglottis as well, and kind of tent it up. There's varying practice, and so people don't find it's very useful, but the laser is really nice as far as they stay.
I guess the study does pose the question to those doing more than what you described, whether it's actually necessary. It was a matter of how much you need to do.
Yeah.
So maybe you go back and study more.
Yeah, for sure. I think that's a challenge with this, because I think you're right. I think you release the 80 folds, and like that's 90% of the procedure. And I think probably those poor results are probably the result of trying to do too much.
And you absolutely right. It's a matter of
So there's just some questions from the floor. From Fiona Kabageni, thanks for the presentation. Is there a reason to cut off of 2 weeks of anti-reflux medication? So the 2 weeks is quite short. I think that we often, even in our practice, we usually give the child up to 2 months of anti-reflux treatment and see whether or not they're responding. But if a child is severely symptomatic with significant features of upper airway obstruction and is really suffering, then we would opt to go ahead with surgery. And the next question is from Kefas Caroline. At what age would you consider any form of surgical intervention? I think that's just taken on a case-to-case basis of how the patient presents, how severe their symptoms are, and whether or not they're responding to conservative management. But there's not necessarily a cutoff in age regarding to the surgery.
Well, thank you. That's really excellent. I hope you won the prize for that.
So unfortunately, because I'm not a pediatrician, I wasn't considered
For the prize.
for the prize. Yeah, so but
We'll do the same as they come to get
yeah.
No foreigners and no.
Thank you. Thank you very much, everyone.
That was great. Well done.
Thank you.